Okay. Do you want me to start? Sorry, I'm
Yes, I do want you to start.
okay.
Yes, thank you.
Okay, Kateryna and Alexandra, I would like to thank you for the invitation. I show you now that I was briefed to talk about follow-up for prematurely born babies as a service. And if I move on, the brief I was given to talk about what are the major domains that are affected by preterm birth. Then secondly, who and when should infants be followed up and for how long? What matters or what may alter the development of very preterm and very low birth weight babies? What tools should be used? Where should we follow up families and by whom? And who needs the service? So let me start off. I mean, you all know the definition of very preterm birth, being born or preterm birth, being born before 36 weeks of gestation, 37 weeks of gestation. And we have a large group of moderate to late preterm. And then we have got a group of very preterm born who are usually identified those before 32 weeks of gestation. And we have to be aware that prematurity means that the organs are immature and they're being cared for extrauterine at a time when they were not expected, for example, to breathe, to regulate themselves. And some of the treatments we do may lead to superimposed damage to the organs, like giving high oxygen levels, doing ventilation, the type of nutrition we give, and they might be associated with complications. So if we look at the brain at 25 weeks of age, and I will focus mainly on brain development and psychological development in my talk, we can see that we have none of this walnut pattern, which we see at full term. Then we can see how the brain development goes. And very important, between the 25th weeks of gestation and 40 weeks, the brain weight quadruples. So it's 4 times higher from this time to actually full term. So a lot of development is actually happening in the time from which babies can survive nowadays in modern neonatal care to full term. Other organs are in a similar way affected. For example, our growth, the lung, breathing, kidneys, but I will focus mainly on brain development. The interesting thing is, if we look at the brain development of those babies born preterm, in particular very preterm, we can still detect very characteristic changes in the brain in volume, in the limbic system, in the thalamus, which is behind here, cerebellum, and cortical folding and network connectivity still in adulthood, which has been shown by us, but also other research groups. So what does it mean for the development of children? And I will focus here mainly for very preterm and very low birth weight babies. These are before 32 weeks gestation or born before 1,500 grams, or extremely preterm babies, which are before 28 weeks gestation or below 1,000 grams. And as we look at one outcome, which is a motor outcome at cerebral palsy, for the very preterms, it's about 3 to 5%, but it's about 7 to 11% across different studies in high income countries who have suffered cerebral palsy. Developmental coordination disorders in very preterm, very low birth weight, 10 to 20%, but about 13 to 26% for extremely preterm. What can we expect for cognitive development and cognitive outcomes? Our review very clearly shows that one of the major impacts of very preterm birth is on cognitive development and on general IQ. The IQ differences for very preterm are usually 0.8 standard deviation or about 12 IQ points lower. And this is both in childhood, shown here in red, but it still persists into adulthood. And I give you one example from our study in the United Kingdom of all babies born before 26 weeks gestation in the UK and Ireland. We found there is hardly any narrowing of the IQ from 2.5 years of age to the control group till 19 years of age. The differences for these extremely preterm babies were even more than 20 points. And when we looked at, for example, cortical complexity of the brain, of how much there was folding on the brain, on adult IQ, we find a clear relationship. And if we want to explain whether anything has changed from 20 months of cognitive assessment to adult main IQ, we can see it's mainly moderated by also changes which we found in the brain. So I will come back how early we can predict adult outcome. Then another area of concern is the mental health in childhood and adulthood, again in red childhood and adolescence, and in blue adult outcomes. We find that if we look at psychiatric problems after very preterm birth, they're mainly focused on neurodevelopmental disorders, which mean autism, spectrum disorders, or ADHD. And what we find is that, for example, for very preterm, there is about a 5-time to 6-time increased rate of autism diagnosis. It's still a small percentage, but it's increased risk. And we have got an increased risk of ADHD. And I want to show you for ADHD from our study, which was carried out in Germany, of all babies born in the south of Bavaria and the south of Germany. And we have followed them up till 26 years of age. In fact, we are currently following them up at 38 years. And we can see here for very preterm children that they have got particular problems, which you can't indicate is with ADD type of problems here, which you can see, which means mainly attention problems or combined problems, but less specific hyperactivity. And this is the number of controlled children. So we have got about double as often ADHD diagnosis. And in both groups, it reduces into adulthood, but it's now about 3 times as frequent still in adulthood in the very preterm group compared to the control children. So while ADHD diagnosis reduces, it's still higher in the very preterm in adulthood. If we then look at personality outcomes of very preterms, one of the things which has been noticed, and this is a meta-analysis of actual data of 5 studies, which we are currently revising the paper, and we find that very preterm children are more likely to be introverted, so they're less likely to be extroverted, they're more withdrawn, and they're more likely to worry, to show anxiety and depression, which is called neuroticism. They're also less, they're very agreeable, but they're also less likely to be open to new experiences. And I will show you later why that is important. So then we looked actually, how does the environment react to very preterm birth or extremely preterm birth? And we both carried out a study, which I mentioned to you, in the south of Germany, and a nationwide study of extremely preterm. And one of the things which we noticed in both of these groups in both countries is that kids who are born very preterm or extremely preterm are more likely to be bullied by their pupils in school. So they become easy targets to be attacked, to be excluded from the social group. And we find that in particular, we also have got more persistent bullying over 2 to 3 years of these children, of the very preterm children. So if now summarize the major outcomes which affect the brain is that we still have characteristic changes in the brain in adulthood. if I put my pointer there. Oops, there it is. We have got more severe motor problems that persist, like cerebral palsy, but also more often developmental coordination disorder, which are less persistent. There may be changes into adulthood. The cognitive differences on average between very preterm are 12 IQ points, and they don't change on average from early childhood into adulthood. We find a little bit more anxiety and depression, but mainly we find neurodevelopmental disorders in the mental health field, which is ADHD and autism. In the personality, the children who are very preterm in particular are more introverted, more withdrawn. They find it harder to make contact with others, and they're more often more neurotic. And on social development, we find that they become more often targets of bullying. They have got fewer friends and find it harder because of their personality to make friends and show social relationships. This is group differences. It's not a prediction for an individual child. So it's very important. As a group, these differences exist. So the next brief I was given after I've told you about the major outcomes after very preterm, who and when should infants be followed up and for how long? So the first question is who? Is there a prematurity gradient? And then when? How early can we detect long-term problems? Are they stable and can they be reliably assessed, and when? And do new difficulties arise later in childhood, adolescence, and adulthood we cannot detect early on? Okay, let me start addressing this. Now here we have got the results from the Bavarian longitudinal study. At the bottom you see gestational age. Yeah, you can see this. So here would be full term. And you can see up to about 33 weeks of gestation, we found that with every week of lower gestation, below 40, you drop 0.3 IQ points. So between 37 weeks and 36 weeks, on average, the children at 36 weeks have 0.3 lower IQ point. However, we have a turning point at around 33 weeks gestation, where every week of gestation lost is related to a 2.7 point IQ point loss. So someone born at 30 weeks gestation compared to someone born at 31 weeks gestation will have 2.7 IQ points lower. But then you add up all of the IQ points, they're also 2.7. They're now 5.4 IQ points lower than someone born at 32 weeks. Can you see this? So you see a much sharp decrease in IQ below 33 weeks gestation. And we could even predict from our German data, the data in Great Britain for the extremely preterm children from this function. So the gradient is that you find a very gradual decrease in IQ up to 33 weeks, and then it really is exponential, it accelerates, okay? So if we look now at behavior problem, we have got just this paper submitted. You find the similar thing. This is from 36 weeks on, that really below 32 weeks, it accelerates. You get more behavior problems the lower the gestation, but particular as you're at 33, 32 weeks, it accelerates up. So now the question is, how early can we detect problems? And this is a meta-analysis which was only published last week, which shows the correlation from early on to later IQ, and there have been IQ measures up to 82 years of age. And what they basically show, the stability, once you're about 8 to 10 years of age as a child, there's very high stability of predicting IQ up to 80 years of age. Yeah, you can see this. But before in children who are normally developing, we find that still a lot of things can change. The correlations are not as strong. And I want to show you this now for our Bavarian longitudinal study. We assessed with the Griffiths, which is similar to the Bailey test, at 5 months, their developmental index, at 20 months, 4 years, 6 years, and 8 years. And we correlated it with the IQ at 26 years of age. And we find for those children, for the controlled children at 5 months, the assessment, you can't predict anything for the IQ at 26 years. At 20 months, the correlation was about 0.20. Then the correlation at 4 years was about 0.40. And from 6 to 8 years, we get relatively good 0.6 correlations to 26 years. But what I want to point out is that we had very preterm children who later turned out to have clear disabilities. And those children who had an IQ below or developmental quotients less than 70 at 20 months, around 2 years of age, their stability to 26 years was very high. For those children, there was very little change. So what it means is if a child shows more than 2 standard deviations, usually below 70, a DQ, at 2 years of age, whether it's in the Bailey or Griffiths, then it's very likely that they will still show low IQ at 26 years of age. But for those children who are in the normal range, also for the very preterm without disabilities, you still find quite a lot of change over the next few years, and it is not predictive. So other things in the environment may be able to change their IQ trajectory. Okay. Now, the next question is, are there new issues that arise that we can't measure, for example, at 2 years of age? And yes, there are things. There are some things which are starting early on. We are all born into a family, and most of us will also have siblings. So we build social relationships basically right after birth. We also need to build friendships, and they're very important for our well-being. And that usually starts once children get into a group in the nursery or they go to school. And in adolescence, we have actually an awakening of sexuality, and we are motivated to build romantic relationships, to find a partner, whether it's usually from the other sex or with the same sex. And another thing which parents actually expect from us is in adulthood that we start living independent, that we earn our own money, that we have our education, and that we move away from home. And all of these things, having friends, having good family relationships, having a partner, and being independent, are very important for our happiness and our life satisfaction. So here an example of Melanie, who was born 26 weeks at 750 grams here in the neonatal unit. She's born in Germany. Here at 1 year of age, here her 3rd birthday, here her first school day. And then she sent us pictures of her wedding. So it was very important that she was adaptive and finding a partner. But how is this for most children who are born very preterm in orange, or born extremely preterm shown in blue, or moderately preterm children? Well, we find now here meta-analysis which we conducted, and we're analyzing our own data. We find that fewer very preterm children report in early adulthood, around 25 years of age, that they have found a steady romantic partner. They are also less likely to have ever experienced sexual intercourse. At 26 years of age, we found that less than 1% of full-term babies never had sexual intercourse, while for the very preterm children, it was 28% at 26 years had never experienced sexual intercourse. And there's evidence, at least in early adulthood, we are now following them up into the 30s, that they're less likely to become parents themselves. So we do find that there is a fertility gap. And the interesting thing is when we looked at data, for example, national data in Finland, it was found that if you had a very preterm child, the parents are less likely to have another child. So there's a fertility gap there, but the very preterm children are less likely to have children themselves, mainly because they might not find partners rather than fecundity, that they have a reproductive problem. The next thing is, how do they do in education and income? And we now know that they're less likely to get higher or university education. They're more likely to experience periods of unemployment. And we know in particular the very preterm are more likely to receive social benefits in adulthood. So who and when? So the lower the gestation or lower the birth weight, the higher the likelihood of adverse outcome. And the highest risk is below 32 weeks of gestation. But they are also the smallest group, around 1 to 2% of births. And when, well, severe neurosensory impairment like blindness, deafness, severe cerebral palsy, and severe cognitive impairment and autism, severe autism, we usually can detect by 2 years of age. If we look at neurodiversity like ADHD, we usually have to wait a bit longer that we can actually diagnose it with good reliability by 6 years of age. Parenting, of how the child is parented, and I will come back why it is important that we need to, we can see this already in the neonatal unit, and we can observe this in the early years. For peer relationships, we need group settings. And for group settings, it's like in the preschool or in school. And for personality and romance, we often have to wait into adolescence that we can detect whether they will actually adapt to do this. And for independence and work, well, it's very important that we need to look into adulthood to see this. But we're now looking at predictors of independence and work early on. And one of these are, of course, having severe neurosensory impairment. So what may alter the development of very preterm babies and how? And it is very important to understand that the medical model is very naive. It looks at whether you're born very preterm, and then it looks at your outcome later on, and sometimes many years later. And we pretend that nothing happens across the life course, but many things happen along the life course. For example, parenting can have an important influence of how well also very preterm babies develop. How the family cohesion is, whether there are lots of arguments between the parents and whether they have a support network. Whether there's a good peer group like friendships, whether the children are not bullied but are being integrated, and also support of the neighborhood, whether you can actually play and go outside, can have an important effect on the development. Now, I want to show you just on two or three examples, why the social environment is very important in a similar way for full-term children, but parenting in particular, also for very preterm. So we looked at the IQ at 6 years of age of full-term children, here shown on the top in dark, yeah, of children from high social class, middle social class, low social class, defined by education and work status. And we find also in the full-term group that the difference between being born in a family who have got high social class with parents who are university educated, making good money, to some born in low social class, where they have got poorer education, less income, live in poorer conditions, of a difference of about 12 IQ points in the control group. That means that the difference being born into a poor family versus a family of high social class, the difference is the same as being born 8 weeks earlier in gestation. So it's a huge effect of social class. And we find exactly the same effect, as you can see here, from high social class to low social class for those born very preterm, very low birth weight. Yeah. And then you find additionally the differences of being born very preterm. And when we looked at it on the right-hand side here of your picture, yeah, if you see it, looked at it at 26 years of age, we still find the same difference. So we did then this study for all children born in Denmark and for all children born in Norway. And you again find, and this is a probability of needing special educational help in school. In blue, those of lower parental education, intermediate parental education, of high parental education. And again, here's the gestation effect at the bottom shown. And here's the effect of being born into a lower parental education family. And you can see the huge effect of social class, and the same in Norway. And these are countries which have got a very good social support system, also by the state. You find the strong effect of social class. So it's something which we definitely have to measure in outcome. Now, the second thing I want to show you, that there is a particular difference. The effect of social class is whether you're a healthy child or whether you're a very preterm child, acts in the same way. But if you're very preterm, you're even more sensitive, like an orchid, to parenting compared to full terms. What we did, we observed maternal interaction and child interaction by giving one button to the mother and one button to the child. And the left button, you can only draw up vertical lines, and with the right button, horizontal lines. And they had to draw this house when they were 6 years old. And then we looked at their academic performance in school at 13 years of age. And in the control children, we find whether the interaction was low sensitive, moderately sensitive, or high sensitive, relatively little difference. So basically, full-term children, you can plant in a different family environment. If sort of parenting is just about good enough, their outcome is all right. However, for very preterm children, if the sensitivity was low, they were doing much worse than those where it was moderate. And for those where it was high maternal sensitivity, they nearly reached the performance of the children who were born at term. So parenting and the quality of parenting is very important for the outcome of very preterm children. And we now know, and we will be writing on it at the moment, that it affects the health, the wealth, and the relationships in adulthood. So now let me come to the next question. So this is on the outcome and what factors have got an effect on the outcome of very preterm children. So what tools should we use? And I want to show you two. One, which would be the gold standard, is the European Standards of Care for Newborn Health. And I'm, together with Britta Höning, the chair of developing the standards. And later you will hear about these standards on a recorded message by Silke Mader, who is the chair of the EFCNI. The other one is, which we developed, is ICHOM, and I was a co-author of this as well, is a set together with parents and with neonatologists and follow-up experts around the world, a standard chat, which you can also use in lower resources worldwide. And I'm trying to present both of you. And of course, I'm not on the ground in the Ukraine. I don't know the conditions. In particular, you are in a war. So I can only present to you what can be done, and you have to make decisions what is possible within your National Health Service context. Okay? So let me start on with the ICHOM standard says, which can usually be done also in lower resourced environments. And the important thing is that we need to look at mental functioning. So is things like mental health outcomes, but in particular at cognition and neurodevelopment, at physical functioning like vision, hearing, pain, whether they're readmissions, whether there's disability, motor function, but also feeding and growth and pulmonary function. But we also need to look at social functioning, the impact on the family, the communication, the quality of life, the relationship of the child with others, social functioning, and schooling. And how do we do this? Well, let's look at outcomes and tools during hospitalization. So in hospitalization, we need to definitely record the growth of the child during hospitalization, which is head circumference, length, and weight. We need to look in the NICU, we need to look at parental stress of what they are experiencing. Of course, we record survival, yes, no, because otherwise we couldn't follow up, whether they are hearing tests in the neonatal unit, and what is the type of discharge we have of the child. And we should also manage who is going to follow up the child after the neonatal unit. Then we want to look at outcome tools at 2 years of age, which is the time where we first can predict of those or find out those who have got neurodevelopmental, severe neurodevelopmental disability. And for that, in the low resource setting, we won't be able to do this necessarily for all children, for example, with tests like the Baileys, or do a proper psychiatric assessment of autism. But there are tools, and I will tell you more one about these tools. It's like the Parker R to get cognitive and language assessment. Then secondly, like the strengths and difficulties questionnaire to find out about mental health, and the MCHAT-R to find about autism. We still have got the gross things. We can use the K-picture test to find out about vision impairment at this age. The hearing screening tests we can use, and we can look at discharge. And I want to give you an example of the Parker R. The Parker R is recommended as the best outcome measure reported by parents at 2 years of age by the National Institute of Clinical Excellence in Britain, and it has been used all over Europe, and in particular it came into use during COVID because children could not be seen face to face. So we asked parents, and we have done several validation studies on it as well as others, is ask parents to answer a questionnaire. Here, just the first 6 items of 38. We ask them about what the child can say, and there are more words which they have to tick, and also how the child uses the words, like, does your child ever talk about past events or people, which they have seen a week ago. So to find out about their language skills. And these resources are freely available and on the top shown on this site. And there's a digital Parker questionnaire. There's an online calculator. You can obtain data for large data sets to convert them. And it has been translated in 20 languages. I mean, I know you still have got some who speak Russian. In Ukraine, there's a Russian version there, but we don't have a Ukrainian version yet. So that would need to be done to be used in the Ukraine, to be translated and back translated. And their standardization was published in the Lancet, Child Adolescent Health, and how it was done on over 8,500 children. Their recommendation in clinical guidelines of different countries to use the Parker R, and their validation studies by our group, but also here in Italy, of comparing it to the Bailey scales. So what we are suggesting is that if you don't have the resources to do for everyone the Baileys, which takes 50 minutes, the Parker R can be done by parents. You can screen out those who are likely to have severe neuro and language problems, who can then be assessed with the Baileys, which would save a lot of time and a lot of costs. And it could actually be in the follow-up. One can then focus on those, on other areas like on parenting, etc., to assess which can assist the child to develop better. Now, what can be done as outcome tool at 5 years of age? And here we can, this is on quality of life, the TAP quality of life assessment, again, the growth standard. There is a CDC, which is from the United States, milestone checklist. Again, this can be done with the parents together. We look again, can do the K-picture test for vision, hearing test, and we can look at the current education of the child. One could do more to do also about parenting to find out more. Okay. So that would be, if I've got the iChom, and I can see that I presumably have to speed up. If you have got more resources, then one can use the EFCNI standards. This is the European Foundation for Care of Neonates and Infants. And we have developed these standards, and all the resources are fully available on the site. At the moment, we are revising them. And for follow-up, there are 16 standards. So it's developed, coordinated by myself and Britta Höning as the chairs. And again, we do have got about motor, hearing, and visual assessment, the gold standards for ADHD, anxiety, depression, autism, how to assess executive functioning, general IQ, and physical health. But we also have got standards on parenting, of how we can assess that, parental mental health, because that has an influence on the child, how the school environment is, how the peer and sibling relationships are. And there are further standards. I moved too fast. On the transition from hospital to home, how to manage it, the coordination and integration of care after discharge home, standards on immunization, but also reproductive counseling for the parents, because parents are often very worried, should I have another child after I had a very preterm child? Then meeting special needs in nursery or in school, on respiratory health, and on healthy lifestyle. So at 2 years of age, there is a big focus on cognitive development, physical health, neurodevelopment, social development, but also on parenting and sibling relationships. And then the next assessment after 2 years should definitely be at the transition to school. And it's different. In Britain, for example, children go to school at 4 years of age, go in at 4 to 5 years of age. While in other countries, they only enter at 6 to 7 years of age. And we usually do it half a year before school, a jump there, before school entry. Yeah, and again, cognitive language development, school readiness, parenting, and social behavior. Okay. So very important, what do you do with the information? One of the things which we don't want to do is just tell the parents, oh, your child has got a disability or it is weaker in a particular area. We need to do something to help the parents, because otherwise it's a very depressing thing of telling them what the child can't do if we don't provide also some assistance of what parents or others could do. So one of the things for motor is, of course, physiotherapy, but even for motor development and cognitive development, oops, sorry, it keeps on jumping by itself. The most important thing is really to have whether we can have parenting intervention to support them of how they could play with their child, what they could do, help them with sensitivity, also improve the home environment. I know this is perhaps very difficult to do in a war-torn state, but we are talking here from our experiences in high-income countries where we don't have that challenge at the moment, is what we can do to improve the home environment and what we can do for play and language interventions. Once they get the transition into school, and sorry, it jumped too early, it's very important to work with teacher resources. And again, my colleague Sam Johnson has developed resources for teachers of how to recognize the child, because preterm children are not often problematic in the way that they are aggressive and attack other children. Rather, they're more withdrawn, have more attention problems. They're the forgotten children. So it's important to have a package to help them in school. Let me now move on to the next picture. The other thing is, which we do need to recognize, is that we have to help the mental health of parents, to recognize that. Many have got post-traumatic disorder after the experiences in the neonatal unit. They might be very anxious and very overprotective with their child, which is not good for the child. So it's important to look at their quality of life. The good news is when we followed them up 27 years later, their quality of life was as good as the quality of life of parents who had a full term. And then we look at the comprehensive assessment. It really has got an effect on later development. So it's important to take into parenting and the family. So if we start assessment, and for some reason I make drawings on my page, is assessment of the child and family function. It's important that with this we can improve the quality of life of the child, arrange for appropriate support, and we nearly have to clearly set realistic expectations for the parents and manage it in that way. So let me come to the last 3 slides. So who would need our support? Well, I showed you the earlier born, the smaller born, the sicker are more likely to have more problems. So if you look at it, but there is a prevention paradox. So the smaller ones, the sicker ones, they're about 1 to 2% of the whole population, are more likely, most likely to have more neurodevelopmental problems, etc. But if we focus on this small group, making them better has little impact on the whole population. So that's epidemiologists have said. And those children who are doing all right within the normal range are the most likely, if we focus our resources on them, to improve across the developmental period. And therefore, the decision is always to make, do we focus on the group who have the most likely problems, or do we focus also on the group who are not having severe problems, but actually maybe most likely to do better in the long run? This is called the prevention paradox, analyzed by Rose. So the later born, not so small, like the moderately preterm or under 2,000 grams, are a much larger group, and they're much more likely with early intervention to alter their developmental trajectory. So I want to give you this as a thought. The ones who are the most vulnerable are the earlier, smaller born, but the others, groups which are often forgotten in follow-up, the later born, moderately preterms, not so small, we can make a big difference with intervention in that group. So how should we organize the follow-up? What is the role of doctors and how are these roles distributed? That was the question. So the first thing is, it's very clear that the follow-up should not be done by neonatologists, because we have found that if neonatologists follow up, we find a bias. They find it really hard to see, don't like to see that the outcome is not that good. And the reports from follow-ups of neonatologists are always more positive than those if they're done independently. In particular, if those who follow up don't know what the history of the child was in the neonatal unit. So the gold standard would be, so it should be someone who should follow up, should be a team of people in the gold standard, external by psychologists, nurses, pediatricians who do the assessment, who are not involved in the neonatal unit. And in the ICHOM standards for low resources, we have got parent reports like Parker-R, SDQ, MCHAT, and we need at least one trained person to do the assessment, because we can also train a nurse or a doctor to do, cognitive assessments. But good would be, or psychologists to do motor assessments. I'm sorry that I had to sneeze. Where should be follow-up? Should it be in special premises of the hospital, department, or separate building? Well, in the gold standard, it can be in a hospital, but it can be also somewhere else where you have got dedicated rooms, like a waiting room where the parents can already fill in information, and assessment room or assessment rooms where you can do face-to-face assessments, plus you have got parents' completed form. Ideal would be rooms where you can do the psychological assessment, another for motor and another one for physical assessment where you can rotate. For the ICHOM, it would be good because quite a lot is done postally, and you have got, for those who you call in to do it's because you need to do gross measurements and you need to do a more in-depth assessment like the Bailey scales to have an assessment room. But it can be in the hospital, it can be somewhere else. We actually found in the follow-up that some parents who didn't make good experiences in the neonatal unit, the worst for them was to come back to the hospital and come close to the neonatal unit. If they went somewhere else, they were more likely to take part or another wing of the hospital than not. Then the need, very important, is right in the neonatal unit is to have a database to record, like, for example, when the follow-up should be, when it is scheduled, that parents are given information about the follow-up, when it will take part, and how they can be contactable, particularly in a movable situation, like, for example, you leaving your home, etc. It's difficult to trace them. So it's important to have a mobile number. And we always record also the number and the address of the grandparents of the child. So the parents of the parents, because they might be more stable than actually the family that's moving around and housing. And to reduce disparity, it's very important to reach out in particular to those who are less educated, who are poorer, and perhaps even offer home visits if that's possible. And that's my talk. Thank you very much. Do you have any questions?
Thank you very much, Dieter, for such a comprehensive presentation. I'm waiting until I will be on the screen as well. Just a sec. So, okay, yeah. And yes, we have some questions to you. They were both asked in English, so I will read them in English, and the translator will translate for the audience. So there was first comment and then the question from the same doctor. Diana Akhmedjanova, there is also a potential negative outcome both on prematurity and brain development, prenatal alcohol impact, fetal alcohol spectrum disorders, a large under-recognized cohort of children with brain development impairments. So you might comment on this comment. And then the question, could you please elaborate on the types of specialists, teams of specialists performing evaluation and using tools you've mentioned in your presentation?
Okay. So prenatal alcohol syndrome, yes, it can be can have a very negative effect, but it's also associated with preterm birth itself. Often it's recognized. You need, of course, an anamnesis about drinking behavior, in particular of the mother, in the neonatal unit. And often it's also associated with small malformations of the child, in particular when it was early on, like the ears set lowers and so on. For example, the eyes closer together, mouth changes, facial change, and so on. There are assessments of determining this, so it's important. I can't say for the Ukraine. It's in Britain it does exist, but it's a relatively small problem. And we have done studies in the Millennium cohort of looking at the outcome of these children. And one of the important findings was severe alcohol syndrome. I mean, having, for example, drinking a lot, particularly early on in pregnancy, has negative effects. But we actually found that having, for example, 2 or 3 glasses of wine or beer in a week during pregnancy didn't have a negative outcome on child development into adolescence. We have published 3 papers on this, studying 18,000 children. So it's very important to see it's the severe end, which has got a really negative outcome. The second question is about the team. So it really depends for which you can go. If you go for the gold standard, it would be brilliant to have a pediatrician in the team, for example, trained for doing motor assessments, doing the physical assessment, also on respiration, eye, hearing. Then secondly, definitely, because one of the major outcomes is to have a psychologist or someone who could be trained to do the psychological assessments, like, for example, the cognitive assessments, doing the assessments, interviews with the parents, handing out the questionnaires. And then often what is important is if you've got feeding problems and language problem, it would be good to have a speech therapist. So that would be really sort of an ideal team to do this. But we have found, like with the iChom, in particular if the parents fill in information about the cognitive functioning, about the language, etc., then you could have basically one person, a psychologist, a pediatrician, or a nurse, well, an experienced nurse, being trained in the assessments, like a Bailey assessments or the TOMI or the movement ABC, etc., to do the assessments of motor ability. You don't need specialists, but someone who can be trained and is well trained and has reliability assessments. The important thing is that each team should really, every 6 months, have a reassessment of how reliable they are in the assessment, so that they have got supervision. And that always needs to be done. In our research, we do this every 2 months, and the teams have to send us video recordings so that we can assess that they do it reliably. I hope that answered your questions.
Yes, can you hear me?
Yeah.
Okay.
I can.
I can see that we have one more question from the same doctor. Diana Akhmedjanova, to your opinion, who should have a leading role in the child's follow-up?
The best person. Who's the best lead? There's very clearly, it shouldn't be done by profession. It's not very important. And we demonstrated. I used to work at Great Ormond Street, the Hospital for Sick Children in London. And our department was 1 year, it was led by a pediatrician, the next year by a psychologist, and the next year by a social worker. We had a rotation of the head of the department. And it really doesn't make, and it was very good for interdisciplinary work. So the lead should be really working between the neonatology and services outside neonatology, community services. So the best thing is that someone takes the responsibility to have this link. The second thing is, and this is also in the EFCNI norms or standards, is that you need a caseworker. Is someone who takes on responsibility for so many families and keeps the link with them. And it doesn't matter what profession. It can be a social worker, because parents need a lot of help. They need help, for example, of coordinating appointments with different specialists. They need help of getting social, like for example, financial support, you know, if they're poor, that they can bring up their child. So it needs a caseworker who also coordinates them with the follow-up assessment. So very important is that you identify a person who can communicate, who's dedicated, and who's very good at organizing databases. That should be the person, not a profession or a rank.
And there are two comments which I will read to you from our viewers, and the interpreter will of course translate. І так, пані Надя Фоменко пише: дякую, професор Дітер, за чудову доповідь і глибокий аналіз катамнестичних даних та кореляційних зв'язків у когнітивному мовленні, моторному розвитку та соціалізації передчасно народжених дітей. І також коментар від пані Ірини Кондратової. Дітер дуже вражаюче. Прихована травма педіатричного спостереження в Україні. Як можна прожити та вижити дитині без дитячого невропатолога, хірурга і уролога та інших. Дякуємо за чіткі рекомендації щодо команди катамнестичного спостереження.